So as I have mentioned earlier, today's lecture is a very short lecture, but it is a very important topic. We will discuss about the dermatological uh, problem in a special population, like in pregnancy, in cancer patient, leprosy patient, a special kind of population that you will encounter in your chamber. So let me introduce myself who are new to my class. I'm Dr. Mishkat Amit Aziz. I'm from Bangladesh. I'm an endocrinologist and skin specialist, also a family physician. So without any delay, let's begin the lecture today. So it is a special thing I have told earlier. First, the most common population you will encounter in your practice is geriatric dermatology. Because commonly people will come to you with acne, a facial scar, etc. These are the general population aging from 18 to around 40, 45. But the geriatric population is a special category. There are some certain condition in geriatric population that we have to take care of. First comes the skin aging and age-related dermatologic condition, especially in the high society girls. You will see they will come to you with a skin mark or skin stretching, um, uh, knee on the knee. I'm sorry, not knee, on the cheek. There is a flappy mass. Like this condition, they will come to you. So skin-related causes are divided into two categories: intrinsic aging, that is chronologic aging, which is natural aging process and generally programmed. As per age, the normal changes appear on your faces. And feature comprises of thinning of the epidermis, decrease of the collagen and elastin in the tissue, flattening of the dermo-epidermal junction, and reduce sebum production. So in the geriatric population, you will very rarely encounter the acne because there is very low sebum production and decrease in the skin cell natural immunity and wound healing capacity. Whereas the extrinsic aging, that is photo aging, we call, caused by the external factor like UV radiation or other radiation exposure or excessive sun exposure, that causes these things. Feature comprises deep wrinkles, solar lenticels, that is age spot, small dot-like things in the faces, then ectopic keratosis, telangiectasia, and skin becomes rough and leathery texture. The normal skin texture is changed. Common age-related dermatological condition like in the geriatric population you face, that is xerosis, dryness of skin, which is the most common due to the reduced lipid in the skin. And there may be pruritus, often secondary to the xerosis due to the fragile capillaries, seborrheic keratitis, that is benign pigmented lesion, and onychomycosis condition. The skin. Now the procedure: chemical peeling, laser resurfacing by fractional carbon dioxide laser, dermal filler, botulinum toxin, microneedling with PRP, that is platelet-rich plasma. For dermal filler and botulinum toxin, these are the actually injectable agent used, which I think Medical Global Academy covers in their aesthetic dermatology section. And there are some lifestyle measure you have to advise the patient for UV protection, to use the broad spectrum sunscreen at least SPF 50 plus is recommended. And proper hydration and drinking water, a healthy diet, cessation of smoking and alcohol is recommended. And management of the skin cancer in elderly population, common cancer Ashish Neha, if you have not seen my profile, I have DDV from UK, that is Diploma in Dermatology and Venereology. So we are on the skin cancer in the elderly. That is common skin cancer like basal cell carcinoma, squamous cell carcinoma, and melanoma. And risk factor comprises the cumulative UV exposure, immunosuppression, genetic predisposition. And the management is early detection by the skin examination, by dermoscopy, sometimes surgical excision, which is gold standard procedure, and more surgery for high risk or facial tumor, non-surgical option like cryotherapy, topical 5-fluorouracil, immunoquinone, and regular follow-up and education of the sun protection. Dermatological consideration in geriatric population is polypharmacy, increased risk of drug-induced skin reaction, delayed healing, effect in post-procedural care, that is when you do the Mohs surgery or an excision, then you have to take care of the situation. Cognitive and physical limitation may affect the self-care. Psychosocial factor, skin tissues, and skin tissue may also impact the quality of life and self-esteem. Now, pregnancy and this is a very crucial and sensitive issue because in pregnancy, our hands are very much tight bound that we cannot use any agent because of the safety of fetus. Many dermatological agents are phytotoxic, so this category requires very much attention to prescribe with precise and preventive and sometimes palliative care. So pregnancy and dermatology changes during pregnancy physiological changes like hyperpigmentation, which includes linea nigra, melasma, estrella gravidarum, vascular changes like spider angioma, pamarerythema, and telogen effluvium postpartum. Let's elaborate a little bit about these things. Hyperpigmentation, linea alba is a vertical line that goes across the umbilicus, and it is usually benign, and it is self-limiting. It usually resolves in postpartum period within 3 to 4 months of delivery. So you should not prescribe anything in linea nigra. Melasma is the black patches here and here you see commonly during pregnancy. In non-pregnant women, we use some topical agent and some oral drug. Like you can give tranexamic acid, vitamin C, vitamin E, and hydroquinone, tretinoin combination. But in pregnancy, you should not give anything like that. You should wait till the delivery, and no oral agent should be administered. Some topical agent like hydroquinone may be used very thin layer for a very short duration. Now the estrella gravidarum, it is the stretch mark, simple stretch mark. It usually red or purple initially, becomes silvery white in later stage. To reduce this, you can use retinoids, topical retinoids, also some hydrocortisone topical steroids, and commonly microneedling is done. And after the postpartum period, you can consider the carbon dioxide fractional laser or RBM laser. for the stria gravidarum. Vascular changes like spider angioma, it usually occurs in the face, upper chest, sometimes in the tummy, and these are the small red arteriolar swelling. You can see like red dots in skin. Most of the cases, these are also benign. You don't have to do anything, but you have to if you can, if this is a large or cosmetically there is any disconfiguration, you can consider the dye-pulsed laser for this condition after the pregnancy termination occur. And palmar erythema is simple, the red hand. It is due to the vascular dilatation caused by the estrogen, high estrogen level during the pregnancy. It is self-limiting. You don't have to do anything for that. Here changes is that just after the delivery, there is a condition caused telogen effluvium postpartum. What is that? In this phase, after the delivery, the hair follicles goes from anagen to anagen phase to telogen phase. Anagen phase is the growing phase and telogen phase is the resting phase. That is why there is abrupt hair fall, especially first 3 to 4 months after the pregnancy. This condition usually is self-limiting and totally resolves after 6 months to 1 year after delivery. But on this period, you should counsel the patient for increased protein intake, vitamin E supplement, biotin supplement, and and after postpartum period, you can also consider the 5% or 10% minoxidil spray for telogen effluvium postpartum. Hormonal influence like estrogen, progesterone, and melanocyte stimulating hormone plays the key role during this period. So these are the 3 hormones which is mainly responsible for the skin changes during the pregnancy. Now, managing the pregnancy-specific condition like melasma, that is systemic hypertension on the face, triggered by the hormonal changes, that is UV exposure. I have told stick SP 20 plus wide brim hats should be used. Topical agent also can be prescribed in pregnancy, which is safe is azelaic acid for hyperpigmentation, and vitamin C is also safe in the pregnancy. And I have mentioned earlier that we have to avoid the retinoids and hydroxyquinone during pregnancy, but hydroxyquinone can be used in very thin layer for very short duration if very much severe condition. And postpartum condition, you can also consider chemical peeling, which is done by the glycolic acid. It is also covered in the aesthetic dermatology. It is a hands-on training. You should enroll this if you want to learn more about this procedure in Medical Global Academy. And safe treatment option during the pregnancy is avoid the teratogenic drug like isotretinoin, which is a retinoid of vitamin A, systemic steroid, and favor the topical category B or C medication. I always prefer category B for this. Now, next slide comprises safe option. What are the safe option to use? First safe option is emollient for dryness and itchiness of the skin. For emollient, you can use shea butter, you can use olive oil, extra virgin olive oil, and also you can use some topical emollients available in the market. And topical corticosteroid for short time, I have told earlier. Antihistamine, if there, you can use cetirizine, loratadine, and also fexofenadine can be used in pregnancy. It is a category B drug. And antibiotics like penicillin, cephalosporin, and erythromycin can be given, but you should be cautious with penicillin because there is a high incidence rate complaint of penicillin sensitivity. So even though the textbook advocate the penicillin, I always discouraged to use the penicillin. Now the condition needs the special care, that is pemphigoid of gestation. It is very rare condition, but it can happen. I have covered the pemphigus and pemphigoid and its difference in my previous lecture. You can see. And intrahepatic cholestasis of pregnancy. What is that? You can see from the name, intrahepatic. Within the liver, there is cholestasis, that is bile retention, which causes retrograde flow of the bile, which accumulates under the skin and causes itchiness. So this you also need very special care for the patient. Sometimes we use sodium-oxalic acid to reduce the bile in the blood, which gradually also helps to reduce the bile acid or salt beneath the skin. And pruritic arterial purples and plaque of pregnancy, which is in short is called PUPPP, pruritic arterial papule and plaque of pregnancy. Simple antihistamine is given. Sometimes if there is severity is very much, then you can consider injectable orotaxin also for this condition. Now, here is that is immunocompromised patient like HIV or AIDS patient. They commonly complain about infectious condition, that is fungal, like oral, vaginal candidiasis, and dermatophytosis, which can be managed by antifungal agent. There is a separate lecture for infectious condition. I have detailed elaborated about management of this condition. For viral condition like herpes simplex, herpes zoster, and human papilloma, you can use antifungal topical, but don't use oral antifungal. I'm sorry, not antifungal, it's antiviral orally, because high dose may cause teratosis, and it also category C drug. You should focus on applying for this condition. Bacterial condition comprises impetigo and folliculitis. These are simple to manage, and you should prescribe oral antibiotic, that is followed by mupirocin cream or fusidic acid cream along with this. Some specific dermatosis of HIV like Kaposi sarcoma, eosinophilic folliculitis, seborrheic dermatitis. We have discussed about these things in our earlier lecture. Kaposi sarcoma should be treated postpartum period, not during the pregnancy. And treatment consideration like immunostatus, you have to see that for and with ART and prolonged or recurrence infection are very common in HIV population. একটু ফ্যানটা বন্ধ করেন দুটোটা। Dermatologic condition in transplant recipient. Transplant are another condition because it is a very small group of people, but you may find them like kidney transplant, liver transplant, skin graft. You may find that long-time immunosuppression causes the increased risk of viral wart, that is human papillomavirus. Even the skin cancer like squamous cell carcinoma and fungal infection is very, very common. You will definitely gonna find it if you are gonna see any immunocompromised or transplant patient, commonly onychomycosis and candidiasis. Management is pretty simple: regular dermatological screening, early biopsy of suspicious lesion, immunosuppression dose is adjusted if required, and provided that immunosuppressive dose should be adjusted by considering the ongoing disease condition, prognosis, and the recent skin problem severity. And some preventive care should be advised like sunscreen, personal hygiene, and antifungal prophylaxis. Now, another group of population in this category is cancer patient. Cause of skin cause of skin issues in cancer patient is usually the chemotherapy, like hand-foot syndrome, and alopecia is very common in chemotherapy patient. So alopecia management is a little bit discussed earlier. Biotin, vitamin C supplementation, zinc supplementation, minoxidil spray can be used in this condition. Radiation dermatitis is very difficult to treat. It is usually a chronic process. Sometimes you have to give antibiotics in these cases, and topical ointment, which is sterile ointment or antibiotic ointment. Then sometimes when it is a lacerated wound, short dose prednisolone is also prescribed along with this. Now the paraneoplastic syndrome may also come with acanthosis nigricans or dermatomyositis. Patient in cancer patient you may encounter this acanthosis nigricans usually is also a sign of metabolic syndrome. So you have to consider that it is happening due to the paraneoplastic syndrome, or the patient is obese that causing the metabolic syndrome, or if the patient is female, if she is having the polycystic ovarian syndrome. You have to consider this thing, and then you have to plan your treatment guideline. And supportive care like emollient and topical steroid can be given, cold caps or hats to reduce the chemotherapy induced hair loss, and treat secondary infection aggressively by appropriate antibiotic. And multidisciplinary approach is important in here, because you have to consult with oncology, you have to consult with dermatology. If the patient is diabetic or has a hormonal issue, then you have to consult with endocrinology. So you have to make a coincide plan for this sort of cancer patient. Without seeing his previous prescription, you should not jump into a conclusion for this sort of patient. So let's dive into the detailed management of dermatological condition in each population group we have mentioned. Now, first for the geriatric dermatology, condition like xerosis, I have a little bit elaborated earlier. Implement creams like urea or glycerin gentle cleanser, and avoid the soap and humidifier, and always bath with lukewarm water. And for pruritus, treat the underlying cause like xerosis, renal or hepatic issue, and you can topically apply emollient and oral antihistamine like second generation or third generation. Topical menthol or Prexdomin is also used in some pruritic condition. Now the seborrheic keratosis is usually benign, no treatment is needed. Cryotherapy or curettage is recommended if there is any symptomatic or critical. Onychomycosis, oral terbinafine or itraconazole or any other antifungal you can also choose of your choice. And topical efinaconazole or cyclopyrox is very much less effective. Efinaconazole, cetraconazole, and another agent is efinaconazole, cetraconazole, luliconazole is also used nowadays for onychomycosis. Actinic keratosis is a precancerous condition which requires cryotherapy, first-line treatment, topical 5-fluorouracil, immunocompromised, or diclofenac gel, or photodynamic therapy for multiple lesions. And now management of skin cancer in elderly, we have told in skin condition, we have last lecture, basal cell carcinoma excision or Mohs surgery for facial lesion, and topical immunocompromised for superficial basal cell carcinoma. Bismogedib for carcinoma, which is not common in Bangladesh. I don't know about the India if there is, but in when I was doing my diploma in dermatology, I have seen them use bismogedib. And squamous cell carcinoma, we usually use white excision and Mohs surgery, which is high risk site, and radiation therapy surgery is not suitable. Melanoma is very simple, is surgical excision with appropriate margin and sentinel lymph node biopsy followed by immunotherapy sometime if there is any concern there. Regular dermatological follow-up for melanoma is also advised. Now, the dermatology in the immunocompromised patient. That is, I have mentioned earlier in the HIV and AIDS patient, seborrheic dermatitis is treated with topical ketoconazole cream or shampoo, low potency corticosteroid. Herpes zoster, usually oral acyclovir and valcyclovir, start early to reduce the severity. For warts, cryotherapy or immunocompromised, which is less effective in advanced immunosuppressive patient, and Kaposi sarcoma, antiretroviral therapy with local radiotherapy or chemotherapy or even liposomal doxorubicin used for chemotherapy. Dermatological condition in transplant patient. For this, like I have mentioned earlier, herpes, human papilloma virus wart, cryotherapy, electrosurgery, or imicumod. And squamous cell carcinoma and basal cell carcinoma, usually we perform the surgical excision or more surgery and adjust the immunosuppression if possible. Fungal infection, if locally confined, you can use the topical agent, and if there is a dissemination or tinea corporis like symptom, whole body disseminated, then oral antifungal should be used as adjacent therapy. And monitor the liver and kidney function when you prescribing the antifungal agent for long time, especially the SGPT, SGOT, and the creatinine. Regular scanning is very much important for this sort of patient to find out any coincidental finding because these patients are immunocompromised and they very fragile to develop the skin condition. Annual full body scan by skin check, if not possible, even a simple dermoscopy and clinical observation should be done. And patient education is very much important, this sort of people, because if they don't maintain the hygiene, they are not aware of their skin condition and what to do, they are easily get infected and the condition becomes serious in very short course of time. And also they should be advised for sun protection to avoid this upcoming condition if the patient is healthy. Now the management of the dermatological condition in cancer patient, hand-foot syndrome, I have told, usually chemotherapy is the cause of this, and we usually use emollient, and sometimes dose adjustment of drug is required if the excessive dose is causing the disease, and cold compression is also used to ease the condition. And sometimes if it is painful, you can also orally prescribe ketorolac for short duration of time. And radiation dermatitis, you have to do gentle cleaning, steroid cream, or hydrogel dressing is also used for radiation dermatitis. Hydrogel dressing has a very good prognosis, but still it is a chronic condition and prognosis is very much slow. And for paraneoplastic syndrome, you have to treat the underlying malignancy first to symptom relieve the patient. And for that, you should also consider the patient to refer to oncology to have a better evaluation and proper guidance for his condition. And as a dermatologist, you should give the symptomatic care to the patient of paraneoplastic syndrome. Like for this purpose, you can use the steroid for dermatomyositis tropically. Sometimes oral prednisolone is also given if the dermatomyositis is severe. And for alopecia of cancer patient, you should do counseling. Also, you can prescribe wigs or scarves to cover it up to increase the beautification and to avoid any cosmetic issue, and cold caps to minimize the losses. So these are the special population we have discussed, and this is the condition you will encounter. In my clinical practice of dermatology, I haven't seen much of it more than this, and if you have any question regarding this, you can ask me. You are open to ask. And if any other category you want to know, also let me know. So thank you so much for patience hearing. I really appreciate your patience. And that's all for today. Thank you all.
Yes, sir. Yes, sir. Today's class is very much, sir, very informative and very precise, and we are very happy to have the our mentor like you, sir. Yes, sir.
Thank you so much. Thank you all. So
Yes, sir.
anyone
Yes,
have
sir.
any question?
So, sir, no, sir, we have elaborately, you have described the things very well. So, sir, there is no need of any questions, sir. All-
Thank you
No,
so
sir,
much.
no, sir, we are happy. We are happy to hear. And, sir, सर प्रीवियस क्लास में सर जो आपने सर बताया था बहुत अच्छा क्लासेस था